So let us talk about how to manage a patient who has been admitted to the hospital with lower GI bleeding, and you also find out that the patient is on blood thinners. These could be antithrombotics or anticoagulants that are used for secondary prophylaxis. How do we manage this patient? It's important to weigh the benefits and risks of either continuing or discontinuing the antithrombotics. The risk is ongoing bleeding if you continue the antithrombotic, and if you stop the antithrombotic for a longer period of time to manage the bleeding, you're putting the patient at risk for either a cerebrovascular accident or a myocardial infarction. So, GI bleeding in a patient who is on antithrombotics or anticoagulants, one should take extra precaution in managing these patients. And it is a good idea to involve subspecialists in cardiology or hematology to, or even neurology to help us come up with the best management plan for that patient. So let us look at a few scenarios and how do we manage these patients. Here is a woman uh, who has been uh, who is admitted with the lower GI bleeding, and you notice that when the blood work comes back, her INR is high, and in that case, do you jump and transfuse fresh frozen plasma or prothrombin complex concentrate? At what level do you need to transfuse is something very important for us. So, a recent literature has suggested that you could safely do endoscopy and offer hemostatic therapy with an INR of less than 2.5. INR above 2.5 needs correction, and among the different options, the recent guidelines suggest that it is better to go with prothrombin complex concentrate. So the take home message is if the INR is 1.5 or 2 or 2.2, you can still go and treat the patient without having to wait to correct it or the need to correct it. And you could have good outcomes. On the other hand, if it is above 2.5, you should correct it. And the choice is prothrombin complex concentrate. So now let us look at if the platelet count has come down and you notice the patient is thrombocytopenic. And in that situation, what should be your transfusion goal regarding the platelets? So you don't have to transfuse platelets if the platelet count is 100 or a 75, but it is a good idea to transfuse platelets if they drop below 50, and the goal is to keep them above 50 with platelet transfusion. So for INR is 2.5, for platelets is 50K. How about we take another scenario? Here is an elderly gentleman who came in with the lower GI bleeding, and in the past he had a cerebrovascular accident and also has a coronary stent for ischemic heart disease. So he's on antithrombotic therapy, and in that situation, how do we manage this patient? Do we discontinue or not? How long do we discontinue? Do we need to do any form of bridging therapy, etc.? Or do we need to correct that defect? This is a very complex issue, and in these cases, it is a good idea uh, for those who are on anticoagulants to obtain a consultation from the cardiologist who has put in the stent and managing the antithrombotics, a neurologist who knows about his cerebrovascular disease, and also, if need be, a hematologist who could help. So, elderly patients with multiple vascular uh, issues on anticoagulants or antithrombotics, as a gastroenterologist or as an endoscopist, it's a good idea to seek consultation and get the input from cardiologists, neurologists, and hematologists if need be. I hope this is helpful. Thank you.